She recently completed her PhD in the laboratory of Dr. Laurie West, also at U of Alberta, as you all know. And our research focused on immune risk assessment in pediatric heart transplantation related to HLA, non-HLA, and ABO antibodies. The other things I would like to mention that Anne will probably not put in her bio, but I'm just going to brag a little bit for her. Anne is also a living donor. So she did that in the midst of her PhD. And also what you may not know, but I'm just going to mention here, Anne was recently awarded the Queen Elizabeth II Platinum Jubilee Medal. So she's very modest about this, but obviously it's a great achievement and very well deserved for all the work that she does for lab services as well for community. So with that, Anne, take it away.
So this title here today is, really trying to sort of get to the point that we have a lot of, we don't maybe think about ABO in the way that we could, and that it's maybe more complex than we think, and that it's time for some innovation. So hopefully by the end of this presentation, I'll at least have convinced you that ABO is more complicated than you might have realized, and that we have some opportunities and some innovation that we could apply to transplantation and beyond. I have no disclosures. So the objectives I set out for this are including, and maybe building on some of these as well, is to review the ABH, H being O, histoantigen system, and how these antigens are distributed on different cells and tissues in our bodies. I'm going to discuss some of the ways that we look at measuring ABO antibodies now, specifically red cell titers, and some of the limitations that come with that, and some innovation that we could apply to more to measuring ABO antibodies in a way that might provide us for better risk assessment in transplantation. And also then to think about opportunities that we can build on in ABO incompatible transplantation and innovation. So some of you have seen some of these slides before, but I don't want to skip over them too quickly in case it's unfamiliar to some people. And so essentially the A, B, and H, which is O, histoblood group genes, they encode for transferases, enzymes that add carbohydrates or sugar units on our cells and tissues that form our ABO or ABH glycan system. And we naturally make antibodies to ABO antigens we do not have ourselves. And we don't do that immediately at birth. We start doing that around 6 months of age, but we naturally make these antibodies, which is different than something like HLA, where we only make those antibodies when we're exposed to HLA we do not have for ourselves. So these are naturally occurring. That's true for a lot of sugar targets. And so we just make them regardless of exposure to ABO blood groups that don't belong to us. And so, and then another difference between ABO and thinking about things like HLA is that we have to think about IgM antibodies when we think about ABO antibodies. IgG antibodies are important too, and both of them are present, and we have to think about both of these isotypes of antibodies. They're two different types of antibodies with different structures. And ABO matters in transplant because it can cause rejection, and antibody-mediated rejection specifically of if the graft is ABO incompatible. So we have to think about this. And this fact that we don't make ABO antibodies initially at birth is an opportunity for transplantation, specifically pediatric heart ABO incompatible transplantation. And I'll be talking about that throughout this talk as well. So this is, I'm not a carbohydrate chemist, I should have that on my disclosure slide, but this image is, again, maybe you've seen me present this before, but there is a lot of complexity to the way that the A, B, and H antigens are distributed in our cells and tissues. And so there are these different subtypes of the glycans, which are slightly different carbohydrate structures that are distributed a little bit differently. So focusing on blood group A, for example, if your blood group is A, you would have this subtype 2, subtype 3, and subtype 4 glycan on your red blood cells, but your vascular endothelium would only have this. So some parts of your tissue are only going to have this particular carbohydrate or glycan sugar structure and not these two structures. B, we think is a little bit more similar between different cells and tissues, although that's probably something we need to still make sure that we understand completely before we make that statement universally. But definitely for A, we know that there's some diversity between different cells and tissues and the way that those A sugars are represented. So just thinking about that in picture form, your red blood cells would have these structures on them, not individually on each cell. Each cell would have 2, 3, and 4, and your endothelial surfaces only have this sugar building block or sugar structure. So to make it even a little bit more complicated, there's also subgroups of ABO, and the most common subgroup is ABO-A2. So if your blood group is A, like my blood group is A, you have about a 20% chance that you're not this most typical blood ABO-A blood subgroup, which is A1, and about 20% of people who are A are blood group A2. And so this is important in transplantation, and we're going to talk about that a little bit today as well. And it's also really important to remember that when we call somebody A2, if they've been determined as A2 by the blood bank, really they're just not A1. We use a reagent called a lectin, which only agglutinates A1 cells, but really, so if this reagent doesn't cause agglutination of your ABO-A person, they're just not an A1. We don't know for sure that they're this blood group A2, but they're very likely to be this blood group A2. So why does this matter? Why do we care that we have these different subgroups of A? Well, blood group A1 has the A2, 3, and 4 structures on the red cells, although we don't know for sure if they're all equally representative or if the proportions of each might be a little different from person to person or even over time. And we also don't know if there's an impact to being homozygous or having 2 copies of that A1 gene versus having an A1 gene and an O gene, in which case you're still an A1 blood group person, but you might have potentially less A1 on your cells. And there's reasons to believe from studies in transfusion to think that there is more A antigen if you have 2 copies of that A gene versus 1. So that's A1 people, 80% of our blood group A individuals, but about 20% of ABO-A people, as I said, are not A1, and they're the majority of those are this blood group A2. And what we know about blood group A2 is that there's less of this A sugar represented on our cells and tissues. So if this is how much A antigen is on an A1 red blood cell, there'd be maybe representatively about this much, about 25% we think of A sugars on an A2 cell and tissue. And the other thing that's really important is that it's also different antigens that are there. So this A2 sugar building block is present, but A3 is not there, and there's probably very, very little, if any, of the A4 glycan. And again, we don't know if you are A2 versus A2O, if that would be a different amount of sugar. So what's the connection then between our genotype, the genes that encode for glycans, the antigens we see, and antibody profiles? Oops, I don't know why there's 2 of those. That's an error. There should only be 1 of those. Should just be a triad here. And so when we genotype for ABO, then we have these cells that we would say, okay, well, this is the typing, the ABO typing. So here's what we would predict on cells and tissues. And then we could measure ABO antibody profiles to close that loop, just pretend this is not there. And that's great. But there's still a question as to what this genotype is exactly doing, because it's not like a protein where you genotype and you say, oh, I'm genotyping and here's my amino acid sequence and here I know is my protein. You're genotyping for the enzyme that creates the glycan. So that's why in transfusion medicine laboratories, that accreditation standards still require phenotyping. And so this is something that we're going to have to think about if we wanted to incorporate more genotyping into transplantation in the context of ABO incompatible transplant or ABO in general, because we're still going to have to partner with phenotyping using anti-sera to really confirm that the genotype is what we think it is, until we better understand the way that each individual allele or genotype decorates cells and tissues with glycans. So in other words, just taking a bit of a step back, we naturally make ABO antibodies to ABO blood group antigens we don't have. So for an ABO-O individual, You would have anti-A and anti-B antibodies. And so that means that you're compatible with blood group O organs. And that would be about 46% of the population in Canada. And an A individual has anti-B. So then you're compatible with A and O organs, solid organs, I'm speaking of here. And so that would be about 88% of the population that you have compatibility with from a blood group alone standpoint. Blood group B is about 55% compatible with the rest of the population. And if your blood group is AB and you're a patient, you have no ABO antibodies, and therefore you're compatible from an ABO standpoint with all ABO blood group donors. And then again, just in summary, ABO glycans are distributed differently across different cells and tissues. And there are subgroups of ABO antigens, specifically ABO-A2 being the most common subgroup that we think of when we're talking about ABO subgroups of possible different typings. So in solid organ transplantation, if we're thinking about ABO incompatible transplant, there's a few different ways to think about this. And the main reason that we consider this is to broaden the donor pool, because as I just showed you, if your blood group is O, you have limited access to other transplant groups, and that is true for B also. So for that reason, ABO O and B individuals wait longer to be offered transplants and are more likely to be incompatible with living donors. And so if there's a few different ways we think about ABO incompatible transplant, there's ABO identical transplants, meaning, for example, your blood group is O and you receive an O organ, so they're identical, could be A to A, could be B to B, etc. You can be ABO compatible. In other words, an O organ into an A recipient is still compatible, but they're not identical. You could be ABO incompatible, which is a blood group A, for example, into an O recipient. Or you can be what some people call ABO incompatible light, which is where you would have a blood group A2 subgroup with that lesser amount of A glycan as compared to this scenario into an O or a B individual. And again, the reason that we care about ABO so much in transplantation is that these naturally occurring preformed antibodies can result in rejection, and obviously we don't want that. So how do we measure blood group antibodies right now in transplantation? We use something called a red cell agglutination titer test. And so in this scenario, you have serial dilutions of patient's blood or serum, a serum or plasma, and then each of those dilutions is incubated with a red cell. In this example, it could be an it could be an A cell, it could be a B cell. So in this case, if this was an A cell mixed with each of these different dilutions, the last dilution that causes agglutination, in this case of 1 in 16, would be the titer of, so in this case, it would be an anti-A titer of 1 in 16. And so this is the way it's reported to the programs, and this is the test that's done in the lab. And there's some variability in this test that I'll talk about right away on this slide. And so the way that we do that test really varies from lab to lab and study to study. So you can do an agglutination test at room temperature, or you can do it at 37 degrees. You can use different variable incubation times for how long you let those red cells and plasma sit together before you read out the end result of the test. You can use something called a gel card system, where the red cells and plasma are in a gel card that's then spun. These are commercial assays, or you can use tubes, as I showed you. Your red cells that you use for the agglutination might be commercially sourced, or less likely to be the case, but they could be local panel cells. If you're trying to think about, and I mentioned earlier on in this talk, that you can have IgM or IgG antibodies to ABO, and if you want to try to tell those apart, you can use something called DTT, which basically dissociates IgM or breaks apart IgM to try to remove it from the agglutination test, to try to remove that. Or you can add something called anti-human globulin, which enhances the detection of IgG, but you might use anti-human globulin with or without DTT. And this is not, there's a lot of variability in how people do this, and I'll talk more about this when I show you some examples of results. Not only that, but the anti-human globulin that we use from lab to lab isn't the same. Some labs use an anti-IgG. Some labs use an anti-IgG mixed with anti-C3d. There's multiple different formulations of anti-human globulins used in transfusion medicine, and these may or may not provide exactly the same results. And we know that there's variability in this test. This is well published. And so I'm going to show you an example of a proficiency testing survey that shows that. And in case you're unfamiliar, Proficiency testing surveys are sort of like quizzes, pop quizzes that clinical labs get when we're asked to sort of demonstrate that we're proficient in the testing that we're doing for patient care. So we're sent a sample that's unknown to us, and then we provide the result back to whoever's doing the grading. And if we fail these, we don't actually get to function as a clinical lab anymore. So that's pretty good and important that we do it. And so looking at these, this is an example of an anti-A titer performed by over 100 labs. There's a couple differences in methods. So this light pink here line is a tube test that's done at room temperature. And this dark blue, or this blue hashed line here is a 37-degree anti-human globulin enhanced test. So you can see that's obviously a bit more sensitive in picking up titers as compared to this method. But what else you can see is that that across this number of labs, there's a lot of variability in the titer that is reported. So even using the same method, your result might be 1 in 64, or it might be all the way up to 1 in 248. And so this, again, this is a well-reported issue in titer testing for ABO. And, prior to more modern methods right now that we use in the HLA lab, we saw a lot of similar differences between serology testing for HLA antibodies. And so this is just a well-known limitation of agglutination that we see. But it makes it challenging to compare results from center to center or study to study. So I'm going to talk about a couple clinical scenarios where we use ABO-incompatible transplant, and then talk about some ways that we could potentially build some innovation, or we have built innovation into these transplant scenarios. So pediatric infants or heart transplantation, or infants, as I mentioned, when we're born, we don't naturally make antibodies to ABO. We start making those around 6 months of age. So thinking about an O blood group recipient, they would have very low levels of anti-A and anti-B, as shown by these lines here, at the age of 6 months. And so if this O individual receives an A heart, they go on to make anti-B antibodies, as you would expect, because their blood group is O, and most blood group O people would make anti-A and anti-B. But what happens when you've introduced this foreign A antigen early in life is that the anti-A antibodies then they don't develop. So it's an example of a tolerance to a blood group antigen that was present on the heart that the patient received. And so this is important to understand, obviously, and this is of course work pioneered by Dr. Laurie West and published now over 2 decades ago. And now this protocol, this ABO-incompatible pediatric heart transplant protocol, is used internationally. And the reason that this is so important is because infants have the highest waitlist mortality waiting for heart transplants as compared to other groups. And so this opens up the donor pool to be able to receive organs from different blood groups for these infants. But this tolerance that we see to A is actually specific to the glycans that are present on the heart. And I told you before that red cells have subtypes 2, 3, and 4 glycans, but the endothelial surfaces only have subtype 2. So let me just explain that a little further. So here, I should also have a disclosure saying I'm not a pathologist. I hope there's some pathologists listening though, because I have some pathology flavored thoughts toward the end. But what you can see here, this is endothelial tissue, this is heart tissue staining with different monoclonal antibodies. And this very first box here is an anti-A antibody that reacts with all different subtypes of A antigen. You can see that there's staining for A in this blood group A heart. So that's what you would expect. And there's no B antigen detected in the A heart, also what you would expect. And when you use a monoclonal antibody, or an antibody that has specificity only for subtypes 3 and 4, you do not see any staining. The subtype 2 monoclonal, or in other words, an antibody that's only directed to the subtype 2 glycans, does stain this cardiac tissue. And again, this is just another monoclonal specific only for subtype 3, and you can see that it's absent. So this is important because then that foreign object that has now been put into our pediatric heart transplant patient only has subtype 2 glycan. So when you use a tool, and I'm not going to talk too much about the microarray tool for detecting antibodies today, but this is published work from Dr. West's lab showing that the antibodies that the tolerance, the lack of antibody that we make to that foreign ABO-A heart in individuals who are O or B who've received an A heart is actually specific to the glycan that's present on the heart. And that those subtype 3 and 4 glycans can develop normally and do develop normally because the infant does not see those on their donor heart. So they don't develop tolerance to them. And this is really important. And this tells us, this teaches us something about the way our body recognizes ABO glycans. So in renal transplantation, ABO-incompatible renal transplantation, and by the way, I'm not going to talk about ABO-incompatible liver transplantation today, but that is also something that, that can be done and that is done. But I'm going to focus on heart and renal today. In ABO-incompatible renal transplantation, this is different than in infant heart because this is done in the setting where preformed ABO antibodies already exist. These are adults generally, and so they have already formed ABO antibodies early in life. And there are some differences here too between different cells and tissues and the decoration that we see with those different subtype glycans or those different A building blocks or those different A sugar structures. So when you're looking at, again, a subtype 2 specific antibody here, you can see that that stains endothelial and epithelial surfaces in a kidney. Whereas if you were using a monoclonal antibody that is only reacting with the subtypes 3 and 4, then it actually only stains the epithelial surfaces. So ABO-incompatible transplant, kidney transplantation is done around the world, and there are a couple meta-analyses or large studies that look at numerous other studies to try to pull together the information as to like how do these transplants work, what are the outcomes in these patients, and this is one that that I'm sharing with you here. And so really the take home from this is that the long-term survival, the survival after 1 year and other studies looking at 3-year survival is quite comparable between ABO-incompatible and ABO-compatible patients. There's a slight difference, but it's not statistically significant in this study. However, something that this study and other studies have shown is that there is an increased incidence of infection in patients who receive ABO-incompatible as compared to compatible patients. And this infection also is associated with increased mortality. And so this may be suggesting that we use, this may be due to the heavy immunosuppression that we use in the setting of ABO-incompatible transplantation, and perhaps with better risk assessment tools, we could mitigate some of the risk of these infections by not using such broadly heavy-handed immunosuppression. So something though that I want to point out when we think about these studies and look at, especially in a meta-analysis study where so many studies are combined, is that we have a major limitation in our ABO-incompatible transplantation literature. And that's related to that lack of standardization of ABO antibody testing methods that I showed you on the previous slide, where I listed all the ways that the testing can vary from center to center and from lab to lab. And then I also showed you that can be poor reproducibility of the test, even if we're using sort of broadly grouped similar tests. And so that really makes it challenging to interpret the literature and to compare study to study. Also, the antibody isotype, IgG versus IgM, is not really very, that's not always included in every different ABO-incompatible transplant outcome study. And this is really important. So for example, what I'm referring to here on this slide, when I say important, relevant, especially relevant to post-pheresis. So if we use plasmapheresis to try to remove ABO antibodies prior to transplant, we will preferentially remove IgM antibodies because those live in our intravascular spaces, whereas IgG lives in our extravascular spaces as predominantly. So those two things don't pherese off in the same rate. And so if we're not specifically measuring IgG versus IgM, we may be not picking up exactly what we think we're picking up. And then last on this slide, and really important, is that subtype specificities are not currently tested as part of any of our ABO-incompatible transplant studies. So that difference between an A subtype 2 versus a subtype 3 or 4 antibody, which we know are distinguished, are differently decorated on different parts of our cells in the kidney, we're not considering that, pardon me, we're not considering that in our studies. Pardon me. And so, I'm sorry, I'm just gonna grab some water here. So, so right now we're using our hemagglutination method clinically. And we have all these pros and cons of this method. So Some of the limitations of this method is that we cannot tell apart those different subtype specificities. It's really difficult, it's technically challenging to distinguish IgM from IgG antibodies. We can try to do it, but it takes a lot of work and it's cumbersome. And at the end of the day, it also may not be as specific as you want. The readout is generally not documented. So if you want to go back and review your results later, that's usually not possible. And we know that the reproducibility of this method is low. But it's a good method because it's in the lab, it's easy to perform, it's relatively inexpensive, and it's relatively quick to do. So in the HLA realm, where as Esme said, I've worked for a few years, we've had a real evolution of the antibody testing that we do to measure HLA antibodies. And of course, we know that HLA antibodies are incredibly relevant in transplantation, and they inform risk assessment for us pre-transplant and post-transplant. And they're a really important part of our transplant workup and our transplant compatibility testing. So, in the past, from the late 60s, we used 1960s, we used complement-dependent cytotoxicity assays, where we took lymphocytes and incubated them with plasma or serum from the patient, and then looked to see if those lymphocytes had experienced lysis. And then we started building on this test by adding in different enhancement, like anti-human globulin, like we sometimes do with transfusion medicine testing now. And then we evolved in the sort of late 90s to an ELISA antibody detection method, and sort of concurrent to that, also started using flow cytometry antibody detection methods for both antibody identification as well as cross-matching, which actually started in the 80s. And then ultimately, we've evolved to a Luminex-based, which is a bead-based antibody detection method, which has really become our gold standard for HLA antibody testing. So when we think about this as compared to ABO antibody testing, we're really still in these stages of evolution, where we would then have red cell agglutination and red cell agglutination with enhancement. And as far as clinical practice is concerned, we haven't really moved into any of these types of assays. But we could leap forward into this stage because we have a lot of experience now in the histocompatibility laboratory using this method, and it's possible to consider this method for ABO antibody detection. So we developed an assay to do that, and this was work I did as part of my PhD work in Laurie West lab in collaboration with all the excellent people in that team. And so individual subtype glycans can be coupled, A and B glycans, to individual Luminex beads, as well as H, which I'll show you later in this presentation. We have a no antigen control bead, we have a positive control bead, and then we can use positive and negative control serums so that we have something we can consistently use as a quality control from day to day and run to run. And essentially, this is the crux of how this test works. So we have uncoupled beads or naked Luminex beads that we then couple to individual subtype glycans, and then we can pool all those beads together. So simultaneously in one well, we can test for antibodies to all these targets. We can use a very small volume of serum, less than 20 microliters is required. And then if there's IgG or IgM antibodies present, they will bind to their relative target bead. And then we can detect those beads using anti-human IgM or anti-human IgG, which is color tagged, fluorescent tagged, and then run it through the Luminex instrument and get a readout that looks something like this. So this is an example of an ABO-A individual who has reactivity to B ABO glycans. This is an example of an ABO-O person's profile of antibody to A and B, both IgG and IgM. And here's an example of an ABO-B person's antibody profile with a reactivity predominantly to A, although as you can see with B, some of the antigens that we lack ourselves, we can still make antibody to those. Subtypes, I'm not going to talk a lot about this today, but subtypes 2, 3, and 4 are most relevant for A, subtype 2 is most relevant for B, and these other glycans have relevance in different ways for cross-reactivity, as well as potentially for other representation of glycans that we don't yet understand. So what happens here and what do we see when we start using this new tool to measure ABO antibodies? IgG is a really important part of ABO antibody profiles. And this is interesting because if you look at O versus B individuals, everyone who's a blood group O or blood group B would have anti-A antibody, and the level of the amount of IgM antibody, first of all, you can see that in any individual, this varies a lot. So some people might have this much antibody if their blood group is O, or this much antibody if their blood group is O. And that's true for B as well. And for the amount of IgM antibody that's present, that's really comparable between O and B individuals for anti-A antibody, and also for O versus A individuals for anti-B antibody, really similar levels between those two blood groups. However, if you start to compare the levels of IgG antibody for anti-A in an O versus a B person, you can see that there's a lot more anti-A IgG antibody in O individuals versus B, which tells us something about potentially transplant risk if we're crossing ABO barriers in an O person versus a B person. And that's also true for the amount of B antibody in O versus A individuals. There's a lot more IgG anti-B as compared to in an O person as compared to an A person. Another thing that's important to note is if you're looking at subtype 2 specifically, there's also a big difference in the amount of IgG antibody to this target in B individuals as compared to the targets of subtype 3 and 4. Again, this is really relevant in ABO incompatible transplantation if you're thinking about endothelial surfaces, because they would not be, this would be the antibody that we'd be most interested in. So also another point, just then looking at O individuals, there's a subset of O individuals, even though I already told you they have more IgG antibody as compared to B, but there's a subset of individuals who have less IgG subtype 2 antibody relative to the amount of subtype 3 and 4 antibody. Again, meaning this is the endothelial target, and these are epithelial targets. So if, although these are also on epithelial surfaces, but this is possibly, you would predict a potentially more important antibody to consider in ABO incompatible transplantation. And so there are a subset of people, O individuals, who have a lot less subtype 2 anti-A as compared to subtype 3 and 4 anti-A, although that's not true for the level of IgM antibody to those targets. And so this pattern we would never be able to see using hemagglutination methods on red cells, because we wouldn't be able to distinguish the amount of antibody to subtype 2 versus 3 or 4 in a very any kind of a logical way. So how does a Luminex ABO antibody compare to agglutination? This is a lot of information on this slide, so I'll walk you through it. So these are the anti-A across the top. This is anti-B across the bottom. And this is focusing only on IgM. And on the right-hand side, I've added in the IgG levels of antibody also. So using a hemagglutination titer with no anti-human globulin enhancement, you would expect that you're predicting potentially detecting the majority of your antibody would be IgM driving this titer. And you can see that there is sort of a rough increase over as the titers increase in the amount of IgM antibody. But you can also see that within each titer, there's a broad range of a level of IgM antibody to the A and B target. And when you add in the level of IgG antibody, you can also see that there is most likely, even though IgG antibody isn't thought to be a main driver of a hemagglutination assay until you enhance with an anti-human IgG or an anti-human globulin reagent, there appears to be a contribution of IgG antibody to some of these standard titers. And I think that is something that someone in transfusion medicine would also agree with, and that's something that they would see in all of their red cell agglutination work that they do. But again, the takeaway for this slide would be that within each titer, there's a broad representation of the amount of IgM and IgG antibody. And so one other thing that we wanted to look at then with this assay, this Luminex-based assay, is it more reproducible than the red cell agglutination test, which we know when we look at results between different labs, there's a lot of variability. So we sent these beads and the bead set and a set of sera to 9 different laboratories internationally. And what we found, this is just a representative example from the positive control, looking at the IgG level of antibody to A and B, is that there was quite good reproducibility from lab to lab, and the concordance seemed fairly strong. So these are all labs who've done who've not used this assay before, although they had been familiar with using Luminex assays for HLA. The first time that they're using the test, and all testing the same samples, using different instruments, using shipping these samples around the world. And there was also good reproducibility. Within the set, we included a sample that was the same. They were all blinded, so laboratories didn't know that. And there was good agreement between those duplicates of the blinded same sample that was sent. So it was good inter and intra-laboratory reproducibility. So again, I'm not talking a lot about this microarray assay, although it was the predecessor to this Luminex assay. And I mentioned it earlier when I was talking about the ABO incompatible pediatric heart transplant antibody profiles post-transplantation. But this Luminex bead-based assay is potentially very good clinical fit because it overcomes these limitations of the red cell agglutination, but it also overcomes some of the limitations of the array assay in the sense that histocompatibility labs have this equipment and expertise, and it's fairly short to run. It's more reproducible than the array because the settings on the Luminex machine are static and you cannot change them. And the only difference I would say as compared to the agglutination is that there is an increased cost for running this versus agglutination, which has a low cost. So some take-home messages about antibody assessment are that red cell agglutination can't provide us with the subtype-specific antibody determination that we would want in order to really assess ABO incompatible transplant risk, and that there is a wide range of IgG and IgM antibodies within each titer. And that if we had a better way of assessing risk, this could potentially improve the risk assessment for ABO incompatible transplants and perhaps allow us to tailor immunosuppression to not be so heavy-handed in some of these ABO incompatible transplant settings. So switching gears a little bit, I wanted to just talk briefly about ABO-A2 ABO incompatible kidney transplants. In Canada, we do very little of this, but it is more common than a full or like in other words, putting an A into an O individual. So these are those ABO-A2 organs that have less A sugars and slightly different representation of sugars as compared to an A1 or the more typical A individual. And the reason that we would consider this is because it adds additional donor options for our ABO-O and B individuals who are disadvantaged on our wait list and wait longer for offers for transplant. And so an ABO and anti-A titer is performed, and if the titer is low, then these are typically done without any additional interference or change to immunosuppression or pheresis pre-transplant. And although there isn't a consensus for the best way to measure ABO antibodies in this ABO-A2 incompatible transplant scenario, most laboratories use something that was an assay that was pioneered or sort of used consistently by the Midwest Transplant Center program in Kansas City. This is the work of Dr. Bryan and his team. I didn't list a specific reference here because there are many. Basically using this assay where you DTT treat to essentially remove IgM, and then you don't enhance with any anti-human globulin, you're essentially only detecting very high levels of IgG antibodies in this setting. So what does that maybe look like from person to person? Here are two real examples of ABO antibodies in renal transplant patients, looking at their Luminex antibody profile as well as their different agglutination titers. So both of these individuals actually received ABO-A2 incompatible kidneys. One is a blood group B, this patient. This is a blood group O patient. And as you can see, there's some differences between these two in the level of their antibody. If we're focusing on anti-A2 specifically, which would be the only relevant target in this setting, perhaps there's a very minor influence of A subtype 4. I think we still need to explore that further. You can see their titer was identical using the DTT treated no anti-human globulin method. But once you start modifying and looking at different titer methods, when you remove the use of DTT and you do not add anti-human globulin, this is what's sometimes referred to as a IgM titer, although of course low IgG could be contributing to that if you're not, because it's still present. there's differences between these two individuals. And then also this bottom method here, this is with anti-human globulin, so enhancing for IgG, but not removing DTT. So we tend to call this an IgG titer, but I think that's a bit of a misnomer too, because of course IgM antibody is still present and could be contributing to these titers as well. So you can see, just start to get a sense of the variability that you get as you start to try to compare these. So another thought I want to leave with you, or just raise for discussion, hopefully at the end here, some thoughts, is we use right now A1 red cells to perform titers, even for A2 kidneys. So an A1 red cell has these sugars, A2 kidney only has this sugar, and we tend to not use A2 red cells, even though we could, to measure titers in the setting of ABO A2 incompatible transplant. And I believe that the rationale for that is that this is more sensitive because there's a lot more A-glycan on this cell than on this cell. But I'm just sort of throwing it out there that perhaps we're not using the right cell, and that perhaps we'd be better off to use this red cell, but to enhance for detection of antibody by using things like anti-human as we continue to use these methods in collaboration with potentially Luminex-based methods. I'm going to just discuss a couple other pediatric heart transplant cases here as we kind of come toward the end of this talk. And I'm going to bring this up for a reason, thinking about, relative to how we think about antibodies in setting of renal transplantation as well. So this is a case study where a patient from Pittsburgh, a patient who was transplanted at 6 months of age, received a heart transplant. Their patient is O. They received an A2B heart, and they went on to develop anti-A antibodies. This is using an A1 red cell. This is, they're quite high levels of titer, both at room temperature, non-AHG, and with an anti-human globulin. AGT is their way of describing anti-human globulin. And these are over different time points from 3.5 to 7 years post-transplant. So you can see this presence of anti-A antibody is consistently there. Patient was clinically well, and when we looked at every one of these time points, each one of these colored bars is a different time point, you can see there was no A subtype 2 IgG antibody, but that there is donor-specific, donor-relevant A subtype 2 IgM antibody, but this patient is clinically doing well. And we had a local transplant case that also had a very similar picture. So a 5-month-old blood group B patient who received an ABO-A heart at 6 months of age, and 2 years post-transplant at routine follow-up, doing well, was found to have an anti-A titer emerging of 1 in 8. And we retrospectively went back and genotyped this donor because we don't routinely distinguish between the different blood group subtypes in our lab here. And we're able to genotype them from stored samples in the HLA lab to show this donor was actually an A2 heart, not an A1. And we saw this exact same profile of antibody we saw in the Pittsburgh case, where there's no IgG antibody, but there is IgM antibody. And again, the patient is doing clinically well. And when we repeated this titer, by the way, using A2 cells, red cells, the titer was negative. So I'm just, throwing this out for discussion that we use this term accommodation to describe what we see in ABO incompatible renal transplants, where we transplant across the ABO barrier in the presence of preformed ABO antibody. And even though it's common to see detectable antibody responses to the allograft early post-transplant, that these patients go on to do well. And perhaps this is maybe what we're seeing in these individuals and the sort of apparent lack of tolerance, although it is a functional tolerance despite the presence of IgM antibody to the allograft. Perhaps this is teaching us something about what we see in ABO incompatible renal transplant as well. So we're in the process of identifying additional A2 heart donors and looking at the antibody profiles in more patients. So beyond ABO A2 donors, I'm going to describe another case that was referred to us. So this is an ABO-O individual who received a B kidney. And prior to transplant, there was very low levels of anti-B antibodies detected. So the titer was 1 in 2, sorry, this is a bit confusing here, ignore this, 1 in 2 without AHG and 1 in 8 with AHG. So low levels of antibody that would be considered by most programs safe to cross. But even in the OR, in this case, it was apparent that there was something that was not right, and there was evidence of rejection, which was then immediately treated. But it created a lot of stress and anxiety, obviously. And so when we went back and tested this patient's serum, using Luminex-based method, we could see there was actually a very high level of IgG antibody that for some reason in this case was not detected using the red cell titer with anti-human globulin. So I think that this discrepancy between the HG titer and the level of IgG ABO donor-specific antibody is probably not a common discrepancy, but maybe this is one of the examples of those cases that don't go well that make everyone sort of nervous in general about ABO-compatible transplantation. And perhaps these are differences to ABO IgG subclass. So in other words, IgG 1, 2, 3, or 4 differences, or perhaps the selection of anti-human globulin used to perform this test. As I mentioned earlier in this talk that you can use different types of anti-human globulin, anti-IgG, anti-C3d, a mix of both, etc. So it's something to think about. And since xenotransplantation is such a hot topic right now, I thought I would just really quickly talk about that in the context of ABO. Pigs, which have been recently used in very well-publicized cases for heart and kidney transplantation, can be blood group A or B. The knockout pigs used in xenotransplantation that we've seen recently by commercial different companies who are making these organs are blood group O. But we know that there are some differences, even if they're potentially minor, between the H transferase, H encoding for O, in pigs versus humans. And I've put a reference here to talk about this. It's an exon 8 deletion, which is quite a large deletion. So we're not quite sure exactly how that might affect change on O structures versus in pigs versus humans. But probably more importantly, I think something we don't maybe fully understand is what glycan modifications differ between pigs and humans. So the H glycans are present on both, but are they modified in the same way with other different sugar structures being put on top of those H structures, which we know is something that happens. So just as an example, this is an H profile in a human kidney transplant patient, I guess I need to say human, where that you can look at the levels of H antibody. And this is an example of a higher level of H antibody than we may typically see, but there is a lot of variability. Even in O individuals can have some low levels of anti-H antibody. And in this case, you can see it's predominantly an IgM picture. But I think it just raises the question, is this relevant in xenotransplantation, these H antibodies? This is something else that we potentially need to think about as we start to explore xenotransplantation as a solution to our our shortage of organ transplants. So on the horizon, I could talk about this for a long time. So I just picked a few things to kind of specifically hone in on. I think that we need to further understand the differences between red cell titers and this Luminex assay that I showed you, because we need to understand what are the differences and are they important? Are there, I believe that we would need to run these in parallel for the foreseeable future to really understand the differences. But, and this is a big but, this requires us to standardize how we do red cell titers. We can't compare apples and oranges and bananas and all the things because they're not the same. And we know that we use a lot of different methods for red cell titers, and we need to stop treating them as if they're the same because they're not. And we don't maybe fully understand the pathology of ABO incompatible transplant biopsies, endothelial versus epithelial cells, looking at those differently in the context of those ABO antibody profiles where we can look at the subtype specificity. And I also think we could then consider molecular methods of exploring these biopsies to understand the signature of ABO incompatible transplant better in the context of the ABO antibody profile that's there as defined by a method like the Luminex method. And I also really think that we need to seriously consider the use of A2 red cells to assess for ABO A2 incompatible transplant candidates, at least in parallel with A1 to begin with, because we may be excluding individuals who could be listed for transplant. And this is something that we're currently collaborating with Dr. Kathy Murphy in San Antonio to look at more carefully. And so stay tuned for that as well. So I'm going to leave with a sort of a question for you to ponder. It's a little bit controversial maybe, but for clinicians, for patients maybe listening or donors, if you are a blood group, if you have a donor recipient by sibling pair living donor scenario where you have an ABO incompatible but an HLA identical living donor versus an ABO compatible but high antigen mismatch maybe from a deceased donor or a KPD cycle, which of those two things is better? What would you want for yourself? based on everything I just said or what you already know? Are we doing the right things in these scenarios? Because right now, this is typically what we end up doing as compared to this, at least in Canada. So I just want to end by thanking the giant team that's in the West Lab, the many students who've worked on this, the patients and donors and volunteers who provided samples, the many funding agencies that helped, all the staff in the HLA lab who have definitely assisted with letting me bombard the Luminex machine in the West Lab to acquire a lot of these runs, and our clinical collaborators. And I will stop sharing my screen, and I think we have a little time for questions. Hopefully I'm able to answer those.
While we're waiting, while people are digesting all this information that you just provided to them, I just have a question, and it actually ties into your last slide, because right now, like here at University of Alberta, we do not do ABO-incompatible kidney transplantation or liver transplantation as far as I know of, but we have a lot of highly sensitized patients on the wait list that are, you know, often waiting multiple years before we find a good HLA match. How well does ABO antibodies respond to antibody removal? Is it like, if we do plasmapheresis, how long do they stay away? Do we see different subtypes coming back? Does it change over time with the different subtypes that you showed? And are we disadvantaging our highly sensitized patient population by not looking into ABO-incompatible solutions?
That was a lot of questions, but I'll start by saying that so we have in the past, especially for ABO-A2 or ABO-incompatible light, we have done that in Edmonton. And I think when we initially in 2013 or 2012, when we started our kidney paired exchange national program, we sort of moved away from that because our thought was, well, we have, you know, are there opportunities to find matches for patients, which is true. And we've transplanted a lot of patients who are challenging to transplant through our excellent national KPD program and our highly sensitized patient program. So, I mean, those are solutions, and you can see that both in Canada and really across North America, that everyone sort of had high hopes for that meeting the needs of our O and B individuals in particular who are waiting longer. But the reality is they're still waiting longer, and it doesn't solve everyone's issues of access. So some programs like Johns Hopkins and I think now New York and of course San Antonio have been a bit more more likely to cross ABO barriers in a kidney setting, and that's I think been an advantage for some of those patients. So I do think that it's sort of two things. There's the ABO-A2 mismatch versus the full mismatch, and I think in Canada I know that we're moving toward getting back more to that A2, considering A2 donors for use in O and B individuals, both nationally and within different programs across Canada. And Eastern Canada still does that in a few different programs and have been, and Quebec, I believe, also been consistently done. So we are sort of doing it. And I, as a living donor, if I had been an A2, I'm a boring A1, but I would have been very annoying to the transplant program because I would have said, I would really want you to consider my kidney for an O or B person, like even if it meant only sharing it with specific programs. I would have been very annoying about that, I think, because I think it's important. And I do think that we could, while we could do more, I think we have to be careful because there are certainly scenarios where ABO antibody, like I showed you the case from France, where there was a surprise outcome. And I think those exist in programs where they thought everything would be fine and then it wasn't. And of course, you don't want that, especially, you know, a living donor scenario, well, I guess it's fair to say especially, and of course, then you have more time to prepare. It's more difficult than a deceased donor scenario because you don't have as much time to freeze or remove antibody. So there is this phenomena of accommodation that I referred to in the talk, sort of to answer the part of your question about you know, does the antibody come back or rebound, or how do we remove it? And if it's a fully ABO incompatible transplant, there's always some intervention, whether it's pheresis, you know, rituximab sometimes, depends on the program, different programs. And in the past, even splenectomy was used, which I don't believe anyone is using now. But if you're looking at a big meta-analysis study, those patients would have undergone a variety of different ways to mitigate remove the amount of antibody that's present. And try to prevent rejection. So I think we, first of all, need to agree how we want to measure ABO antibody, even just at the red cell level, because we're not doing that consistently. And then have more studies where we compare like the same methods and the same, treatments as to how we deal with that. But I think it is a way that we can really consider addressing the needs of our most highly sensitized patients, as you referred to. And I think it's worth having a conversation about. And I think we are starting to have those conversations. And I see there's a comment in the chat about KPD not doing ABO incompatible transplants yet, but programs across Canada who've been doing this for some time. And I think I mentioned that in my answer. And KPD, I know, is working toward at least some ABO incompatible light options. So I think we will get there, but definitely less options right now in Canada as compared to some other places.
Thank you. Anybody else have a question for Anne? I don't see any raised hands, I think. No other questions in the chat. Well, if you have any burning questions for Anne, you can also reach her by email or just to congratulate her on all her wonderful achievements.
Well, and I'm curious to ask something maybe of the audience, because it looks to me like there are some clinical people listening. I had that last slide where I said, like, what would you want if it was you? The HLA identical, I should have made a poll for this. I wasn't that organized. But if you had, the HLA identical, but ABO incompatible versus, like a low HLA match, but ABO incompatible, what, like, if you had to pick between those two things, what would you do? What do you think is the better scenario? And I don't know if anyone who's on here who's a clinician wants to weigh in or answer that or put anything in the chat, but I think it's an interesting question. And I'm not a clinician, so I don't have to make those hard choices. But if I were a patient, I think I know what I would want. So I am just wondering, if anyone has any comments on that. Or something to think about anyways.
Yeah, I think you kind of gave them lots of food for thought.